Thank you. Hi, good morning. Welcome to our DOH PCP webinar session for today, entitled COVID-19 COVID-19 in the Vulnerable Population, Part 2. So, next slide, please. So, for the objectives of this talk, general objective to describe the impact of COVID-19 in the vulnerable group, particularly among those with pre-existing illnesses. Specifically, the objectives include to elucidate on the medyo vague. Sorry for that. General objective to describe the impact of COVID-19 in those with pre-existing illnesses. Specific objectives, first, to elucidate on the risk factors related to severe illness due to COVID-19. Second, to discuss the approach in handling vulnerable patients suspected to have COVID-19. Third, to explain the acknowledged interventions to decrease complications and mortality related to COVID-19. And fourth, to enumerate the best measures to prevent COVID-19 in this group of people, to include those with pre-existing cancer and respiratory conditions such as asthma or COPD when they return to work. Next, please. Next slide. So we are indeed blessed and fortunate to have two distinguished speakers, two internists that I would say I admire most, primarily because we're working together. And certainly we are fortunate to hear them in this session. First is Dr. Genevieve D. Agra, an internist as well as a pulmonologist. She is the director of the Institute of Pulmonary Medicine of St. Luke's Medical Center Global City. She's a member of the PCCP Council on Lung Infections and of course a council on COPD and pulmonary rehab. And she's also the chair of the Committee on Health Informatics and Social Media of the Philippine College of Physicians. Second, of course, we are really blessed to have, I should say, the father of medical oncology in the Philippines, Dr. Antonio Villalon, who is the past president of the Philippine College of Physicians and the past president of the Philippine Society of Medical Oncology. And he established, of course, the first training program of medical oncology in the Philippines, and uh, the first to receive, of course, uh, first recipient of the most outstanding medical oncologist, no, award coming from the Philippine Society of Medical Oncology. Again, we will hear from Dr. Gwen Agra first, followed by Dr. Antonio Villalon. Gwen?
Morning. Let me share my slides. Can you see my slides now?
Not yet, Gwen, not yet.
Can you see my slides now?
Wala pa din, Gwen.
Wala pa? Yeah, there. Can you see it now?
Yeah, there. Yes, we can see.
Okay, so I was tasked today to share about COVID-19 in the vulnerable population in those with pulmonary diseases. So why is it important? Because most of our patients would present with cough and shortness of breath. Eventually, they might go into respiratory failure. And some of our patients would have increased age and even presence of other comorbids that puts them at risk to a severe form of COVID disease, especially those with COPD and interstitial lung disease. Okay, in the Wuhan data, um, it has been found, and even now in different areas, that those with advanced age, 50 and above, would have a higher risk for mortality. And it was also found to be higher in males and those with comorbids such as chronic cardiac disease, COPD, cerebrovascular disease, diabetes, and malignancy. In another journal in ERJ, they also found out that those with two or more comorbidities have a higher risk of severe cases, up to 40%. And these comorbidities include COPD, diabetes, malignancy, and hypertension. All of them are predisposed to have adverse clinical outcomes. Why? Because there's some form of immune dysregulation leading to prolonged inflammation, therefore higher level of cytokines and inflammatory injury to different organs, leading to poor clinical outcome. Different societies or different countries have devised their own severity scoring tools to screen patients at the onset upon consult. But most of their screening scoring sheet would involve checking for comorbidities because that, again, is a risk factor for severe illness. So this is from the African Federation of Emergency Medicine. And there's also an online clinical risk score calculation device from Guangzhou. And again, number of comorbidities and history of cancer are part of that scoring system. And why are they at risk? Because patients with COPD and also the smokers have increased levels of ACE2 receptors in their lung. These are the reported host receptors to the virus responsible for COVID-19. And a meta-analysis done by LIPI showed that COPD is associated with a significant over five-fold increased risk of severe COVID-19 infection. But are COPD patients at higher risk of acquiring the infection? Actually, they are at no greater risk of becoming infected with COVID-19 as long as they exercise the necessary precautions, but they are more likely to experience serious complications if they become infected. So how do we prevent infection? Again, make sure that they have enough maintenance meds even during this quarantine. Check with your oxygen supplier or at least have their oxygen concentrators checked if they are O2 requiring. Establish COVID-19 hygiene routine for people in the house, especially if they have house members who go in and out of the house and may carry the virus. Again, frequent hand washing cannot be overemphasized. Hand sanitizer should be within reach among patients who are not highly mobile. And of course, physical distancing in the home. The Global Initiative for COPD is not aware of any scientific evidence to support that inhaled or oral corticosteroids in those who are maintained should be avoided in patients with COPD during the COVID-19 epidemic. They should just maintain their regular therapy, O2 therapy as mentioned. And in vitro models, inhaled corticosteroids alone or in combination with bronchodilators have been shown to suppress coronavirus replication cytokine production. We'll discuss it later. But in earlier guidelines of COPD, not all patients with COPD now are maintained on long-acting inhaled corticosteroid compared to before. What about patients with asthma? Actually, there are no significant number of asthmatic patients documented to have severe COVID-19 in Wuhan data or even in New York City. There's lower expression of ACE2 and TMPRSS2 receptors with ICSUs, which may translate to decreased susceptibility to SARS-CoV-2 infection and decreased COVID-19 morbidity. That's why they're thinking if you have controlled asthma, you actually have decreased risk of infection and morbidity, especially those who are well maintained on inhaled corticosteroids. But then again, we should still coach our patients to have their own asthma action plan. So as long as they have cough, wheezing, chest tightness, and night awakenings, they should be aware that their asthma might be getting worse. And especially if they have trouble breathing and they are not relieved by their relievers, then maybe they should seek consult. So how do we manage a COPD and asthmatic patient with suspected COVID? Is it the same as our other patients? First, one of the guidelines that we drafted early in March within our institute is that we want to minimize the risk of aerosolization, primarily protecting our healthcare workers. So nebulization is still ideal, but then we don't want them to generate a lot of aerosols such that it will pose some risk to our healthcare workers. But in patients with COPD or severe exacerbations of asthma who cannot coordinate using their meter dose inhalers, we can still nebulize in a negative pressure room with setup, the therapist donning a full PPE, or an unvented non-invasive mask with filter, I'll show you later. Or of course, if they are in mild exacerbations, we can use MDIs with spacers or air chambers. We can remind them using instructional videos. Or if patients do not have other adverse reactions to oral bronchodilators, we can also give them. So these are examples of the aero chambers and spacers that we can use to help them use their MDI better. This is a pari-filter valve for patients doing nebulization. Unfortunately, I don't think it's locally available. This other setup is a makeshift setup with your unvented NIV mask hooked to your nebulizer with a filter. So those are our ways to minimize infection. Okay, oxygenation is of primary concern among our patients with COVID. So even our patients who are discharged from the ER with mild disease would be sent home on pulse oximeters and advised to monitor for 2 weeks. However, our patients who are admitted, they are also hooked to pulse oximetry during their course of admission, and they will be hooked to low-flow nasal cannula if their O2 sat is 92 or below. If they're persistently desaturating in spite of 6 liters per minute of nasal cannula, we then provide them a high-flow nasal cannula. These are devices that give humidified, heated oxygen at a higher flow rate, up to 60 liters per minute, and it can provide up to FiO2 of 90 to 100%. But with aerosolization in mind, we just limit the flow rate to 20 to 25 in our patients. And then we monitor our patients. Normally, we use ABG and compute for PF ratio, but to lessen our contact with the patient and puncturing, we use the ROX index, which is the O2 sat over the FiO2 over RR. If you get an ROX index of less than 3.8, that's a sign that the patient might need mechanical ventilation. So when we intubate our patients, most of the time we adapt the ARDS protocol, tidal volume of 6 ml per kilo, and then PEEP of 10, and then we just titrate accordingly. Prone positioning, we use that for patients who are hypoxemic to optimize recruitment of the lungs and to optimize perfusion of the lungs. In different guidelines, most of the time they use prone positioning in patients with ARDS who are intubated already. But in our COVID patients, we actually prone them early on, even while they're on low-flow nasal cannula or high-flow nasal cannula. So, but that's called awake proning. So we ask them to assume a semi-prone position or to prone for about 2 to 3 hours, 3 times a day. ECMO is hardly used in our institution because of increased use of resources and manpower. Okay, so for patients who have COPD exacerbation or asthma exacerbation where we do not have, or in patients who do not want to be intubated, we may try NIV, but using a different setup. Because most masks in NIV would have just some vents that's the exhalation port for the mask. But then we don't want, again, for them to exhale into the room. So we would use a double circuit setup for NIV. And we also discourage ambu-bagging even during intubation. But if necessary, we have to connect them to a viral filter. Okay, another thing is we don't nebulize in patients who are ventilated. So we use a meter dose inhaler to administer bronchodilators to our patients. So how do we do that? We sync the puff with the patient's inspiration and hold the inspiration for about 3 to 5 seconds and make sure that the tidal volume is about 500 ml during that time. So each dose, like equivalent to one dose of nebulization, would be 4 to 6 puffs given 20 seconds apart. Okay, what about systemic corticosteroids? The ATS did not mention much about COPD or asthma and exacerbation, but essentially for patients with COVID-19 who have evidence of pneumonia, they have actually no suggestion either for or against treatment with steroids. But I guess we have to use our own judgment when we want to give steroids in patients with COPD exacerbation or asthma exacerbation, which are especially useful in patients with eosinophilia or persistent symptoms despite maximal bronchodilator medical therapy. And maybe perhaps we should just use the shortest possible course of systemic steroid therapy. So the dictum in treating COPD patients would be to continue their maintenance meds as we discharge them. No need to discontinue inhaled steroid. And once discharged, we have to update our adult immunization. Our flu vaccine for 2020 is already available. And continue home-based pulmonary rehab. I'll touch on that in a little while. And close follow-up, close in quotation marks, meaning not necessarily face-to-face, but we can do telemedicine, but we just monitor frequently. So during this time, our pulmonary rehab patients cannot go to the hospital to continue their therapy. And that would cost them some form of deconditioning. So we would want to institute tele-rehab. So here we are. These are our respiratory therapists who are doing the videos, instructional videos to our patients. And then we'll get them online during their specified rehab time so that they can follow the exercises. So we'll update you as to how this will turn out once we implement them. Okay. Another one gain of this quarantine is that we have cleaner air. But and our asthmatic patients would probably have a little bit benefit. But of course, we also want to keep our areas squeaky clean, no dust and all those stuff. But a lot of times we have patients who have a flare of their allergic rhinitis and asthma because they started cleaning their houses. So when you want to clean the house, if possible, have someone who doesn't have asthma to do the cleaning, and make sure that people with asthma are not in the room. Minimize the use of disinfectants that can cause an asthma attack. Some detergents, or even when you do laundry, the smell of the fabric softeners are too strong, or the bleach, like your Clorox, is too strong that it can cause an asthma attack. Even spraying Lysol too frequently can also irritate an asthmatic. Open the windows and doors and use a fan that blows air outdoors. Clean and disinfect surfaces like things that we take for granted: phones, remote controls, tables, doorknobs, light switches, countertops, and all those stuff. Okay, spray or pour spray products onto a cloth or paper towel so that it won't splatter instead of spraying the product directly onto the cleaning surface. So these are just tiny reminders. Okay, I just included ILD because we have an ILD patient now who has COVID. So they are a very delicate set of patients because of their age and comorbids, and most of the time they are on immunosuppressants. Okay, and they also present with cough and dyspnea. But of course, COVID has a more acute course, while ILD has a more chronic course and also associated with other systemic manifestations like joint pains, skin rashes, and all those stuff. PE for COVID, non-specific on auscultation, while ILD typically has crackles. CT would have ground glass opacities. In ILD, they also have ground glass, but they have other findings like traction bronchiectasis, honeycombing, and everything else. Of course, the labs would also give us a clue as to the diagnosis. General principles on patients with chronic ILD who require frequent follow-up. Ideally, still non-face-to-face or teleclinic, not unless it's urgent. Make sure lang they still continue their maintenance meds. No PFT monitoring. PFT is discouraged even as diagnostic for asthma and COPD for now. And for ILD patients on immunosuppression, continue unless with acute infection. So what about going back to work? I think that's part of the objective of this session. We always have to weigh between the occupational risk and the risk of death. So we know that higher age and presence of more comorbidities would have increased risk of death. What about occupational risk? So they say low risk would be those who work from home or those with physical distancing. Let's say it's just office based and they can sort of plan out their area within the office that they have good physical distancing. Medium would be contact with people with uncertain coronavirus status, like let's say receptionists or security guard in a hospital or in a clinic. High risk would be those with contact with people known to have coronavirus, like in our hospitals. So for patients in classification A, you instruct the patients to wear a mask, just a simple mask outside the home. Practice hand hygiene. Use PPE only when you think you're gonna be exposed. For Group B, discuss individual risks and opportunities to mitigate exposure and to consider stopping work. For Group C, make sure lang they have enough PPE. And if they have high risk, they have a lot of comorbids, then maybe they should consider not going to the workplace yet. Okay, so what's in store in the future as we navigate this pandemic? aside from our immediate mortality and morbidity of COVID-19 patients, our next issue would be your post-ICU recovery, especially those with post-ARDS. And again, like our patients now, those with non-COVID conditions. They have, especially on the third wave, they have interrupted care for patients with chronic conditions. So we need to assure also that they have that we can still care for them either remotely or at least make sure that they have enough supply of medications. And fourth wave, we also have to take care of us, healthcare workers, that we do not experience burnout and trauma. I think this is my last slide. So for our patients, we just maintain that they have their own treatment, optimal treatment or maintenance for their chronic diseases and close follow-up. And for our colleagues and co-workers, we have to check on each other frequently because as we deal with this pandemic, we are braver and stronger together. Thank you.
Thank you, Gwen, for that extensive discussion, giving us tips, of course, especially for our patients, particularly asthmatic and those with COPD presenting with cough. Definitely the risk of getting this particular COVID-19 from them is not going to be easy in terms of discerning which among them really has this COVID-19. Now, may we call on Dr. Tony Villalon, no, for his talk on cancer.
Can you see the slide, Mario?
Yes po. Yes.
Can you hear me well?
Yes, loud and clear.
All right. Good morning to everybody. I'll be discussing the management of the cancer patient in the new normal during this COVID-19 pandemic. Now, these recommendations should be used as guidelines for prioritizing the various aspects of cancer care in order to mitigate the negative effects of the pandemic on the management of cancer patients. The situation is evolving and pragmatic actions may be required to deal with the challenges of treating patients while ensuring their rights, safety, and well-being. So there are so many guidelines in oncology for the different tumor types. We have guidelines for colon cancer, we have guidelines for breast, we have guidelines for lung cancer, and for other tumor types. So what I did, since there's a long list, what I did was to summarize all of these recommendations and guidelines to make it simpler on the slide and easily understood by oncologists, especially those, especially also for the non-oncologists. So who is at specific risk? We all know and mentioned earlier that older people are more vulnerable with underlying health conditions such as chronic respiratory, cardiovascular, or chronic kidney disease, active cancer, and chronic diseases in general. Therefore, the risk-benefit ratio of cancer treatment may need to be reconsidered in certain patients. There are two groups of patients that have been identified. There is a patient who have completed a treatment or have disease under control, which means they are off therapy and only on observation. And patients under treatment with neoadjuvant curative treatment or treatment for metastatic disease. Neoadjuvant means that neo, well, it's a new form of treatment. The standard is chemotherapy after surgery. So when we say neoadjuvant, this is patients are given chemotherapy before surgery and continued to shrink the tumor usually, and also to continue adjuvant chemotherapy after surgery. The second group are patients with active disease. they are eligible for surgery, chemotherapy, or radiation, biological, endocrine, and immunotherapy, again, either in the adjuvant or metastatic setting. Adjuvant means that you give chemotherapy after surgery to prevent recurrence. Now, for all patients, it is mandatory to provide health education, and we are all aware of all these precautions. Avoid crowded places, wear PPE for visits or for consultations. Well, basically, most of our patients would only come in with a mask. Some of them would have a facial protection. Washing of hands according to WHO indication. Avoid contacts with people who have COVID-19 symptoms. And of course, social distancing. For patients undergoing treatment, we should identify pathways in order to guarantee the timing of treatment. In short, we have to explain to our patients after diagnosis when to do the workup, CT scan, x-rays, blood tests, and when do we start the treatment after a 1 week, 2 weeks, or treatment. So this has to be explained very well when the treatment will be started after doing all the workup. If receiving oral treatment, drug supply should be adequate to reduce hospital visits. So, well, at this time, they don't have to go to the hospital for prescriptions because what we're doing now is just take a photo of the prescription and send it to our patients via Viber, Messenger, email, or what have we. Blood tests, again, should be done near home. We always require blood tests for chemotherapy patients before each cycle, and we encourage them to do it near their home and then just send it to us before they come to the hospital. And then we encourage telemedicine services, either by telephone or video call, again, to minimize face-to-face contacts. Of course, with telemedicine, we have heard from many webinars the risk and issues, possible problems with regarding telemedicine. And we are aware of the precautions that you have to take in regards to telemedicine. If possible, we delay follow-up visits. In most cancer patients, those under treatment are seen weekly, every 2 weeks, every 3 weeks. And those that are off treatment, only on follow-up, we see them usually every 3 months, 4 months to 6 months. So if there are no problems associated with their cancer, we can delay follow-up visits, especially if there are no symptoms. More intensive surveillance is needed for older patients with comorbidities. Then strict and safe triaging procedures. Now, this is done very strictly now in most hospitals. So our patients, most of our patients are scheduled in the hospital switchboard or in the triage area, and their names, we submit the names of our patients 1 day before they are seen in our clinic. And we are again restricted. Most hospitals would restrict our clinic days to 2 times a week and for a maximum of 6 patients and for 4 hours each consultation time. So, and when patients come in, they are seen in the lobby, interviewed by our triage officer, and if they are cleared, they fill up certain forms like COVID assessment forms by our residents in the lobby, including the relatives. If they are clear, they are sent to the chemotherapy outpatient or sent to the radiation area. If during interview they are found to have symptoms of COVID-19, fever, or their x-ray shows some pneumonitis or pneumonia, they are sent to the emergency room for proper management and to rule out COVID-19 infection. Before, some hospitals used to have basically or baseline chest x-rays for all patients. But at the moment, since this is not possible, since most patients are complaining about a chest x-ray, since they have a previous chest x-ray or CT scan prior, then as long as they are cleared by the oncologist, then they are safe and cleared to go to their respective areas in the oncology clinic or radiation clinic. Patients who meet the criteria for COVID-19 and other infections should be tested and transferred to COVID-19 dedicated areas. And for those at risk, cancer patients who are at risk, this include patients receiving chemotherapy or radiation, cancer patients taking immunosuppressive agents, and people with leukopenia and low immunoglobulin levels. Nowadays, we are very careful in giving aggressive chemotherapy. You know, we have many protocols that have similar actions. We have protocols, chemotherapy protocols that are safer. They are not they don't suppress the bone marrow, but there are also very aggressive chemotherapy agents which suppresses the bone marrow and can cause leukopenia. So we usually nowadays during this pandemic choose a chemotherapy protocol which are not very myelosuppressive to avoid leukopenia. Once they have leukopenia, they develop fever, they are admitted to the hospital, they receive antibiotics, granulocyte stimulating factors, and they are put at risk for developing infection. Other recommendations would be to do RT-PCR testing for patients undergoing surgery, chemotherapy or immunotherapy, and for patients who present with COVID-19 symptoms. Most hospitals require RT-PCR testing before surgery. For patients under chemotherapy or immunotherapy, we really don't require this as a standard unless they have symptoms of COVID, they have family members who develop infection, they are in an area which is at high risk or with increased incidence of COVID infections. So this is on a case-to-case basis. And if they come from these areas or in contact with COVID patients, then we require them to have an RT-PCR testing before radiation or chemotherapy. And for patients who present with COVID-19 symptoms also. Now, serology should be proposed for previous COVID-19 infection in all cancer patients. Now, although serology, or this is what we know as the rapid antibody test, can be done in some cases, and we know that there is some controversy regarding the use of serology or rapid antibody test. But of course, again, this should be proposed or this could be indicated in some patients for certain indications, especially for a large group of people before going to work. Now, we assess severity by clinical, radiological, and biological tests. So we do X-rays or CT scan and other biologic tests. And again, sometimes it's difficult to evaluate patients with lung metastases who also may develop ground glass appearance when they receive some chemotherapy drugs. Some chemotherapy agents can cause ground glass appearance. So, and we know in COVID infection, sometimes CT scan will show ground glass appearance. So, sometimes it would be difficult to assess whether patients with lung metastases or patients developing ground glass appearance due to some chemo agents is due to that, or these patients could be developing COVID infection. Of course, our infectious disease consultants and our pulmonologists are the best persons to assess these patients. And lastly, we evaluate the need for patients for confinement in dedicated units. Now, we have now in our hospitals, we separate the COVID patients from the non-COVID patients. We have different floors located afar from the COVID area. So in some hospitals, the cancer ward or the oncology unit is situated far from the COVID floors or COVID areas. Then again, telemedicine should be recommended rather than face-to-face. And this again, this can come in form of telephone or video calls. We avoid face-to-face consultation as much as possible. Decisions for treatment initiation or continuation must be discussed for all these patients if they are fit to be treated and willing to do so after proper risk-benefit explanation. So what's happening now? For patients who will receive treatment, radiation, or chemo for the first time, we have to discuss whether we can delay the initial treatment after a few days. At the moment, we are receiving government guidelines every 15 to 30 days. Before we had May 1 to May 15. Then we had another guideline from the government from May 15 to May 31. So every 15 days, we receive notices. So what's being done now is to wait for the next decision. Like this is May 31, we are again awaiting a new directives from the government. What be the what we're going to follow from ECQ to GCQ starting June 1. So which means that sometimes we tell our patients to wait for June 1 for more directives from the government before we can start the chemotherapy or radiation treatment. For those who are already on chemotherapy or radiation, we can discuss with them if we can postpone or increase the frequency of the treatment. With chemotherapy, for example, which you give for every 2 weeks, then we can probably delay this for every 3 weeks or every 4 weeks. For those undergoing treatment every 3 weeks, then sometimes we discontinue it for 1 or 2 weeks and then play it by ear and then reinstitute treatment after a few weeks once the situation clears. If surgery or radiation for early stage is planned, explore the possibility of postponing or using a wait-and-see approach or prioritize treatment balancing the cost-benefit ratio in income and impact on the outcome. So if the patient is for surgery or radiation and it's early stage, then if it's early stage, then again, we discuss the feasibility of postponing surgery or radiation. Now, right now, many hospitals have closed their operating rooms, and many of our patients have to wait until the operating rooms for elective surgeries can be done. Because for the past few weeks, only emergency surgeries are allowed. Elective surgeries are not allowed. But recently now, in the past few days, they are now allowing surgery, elective surgery to be done. Now, and also, we can switch from IV to oral. As you know, there are many oral chemotherapy treatments, oral treatment, which can be given to our patients so that they don't have to go to the hospital for the intravenous treatment and just take it orally at home. We prioritize adjuvant therapies in patients with high-risk disease who are expected to derive survival benefit. So if there is a reason to improve survival, then we give the adjuvant therapies. We should discuss the risk benefits of palliative therapies and options of drug holidays and stop-and-go maintenance. Now, we have patients with metastatic advanced cancer. We know that there is no cure. We know that we cannot improve the survival. So the main objective of treatment is palliative. In short, to reduce symptoms and make them comfortable. So in these cases, especially if the symptoms are not really distressing to the patient, we have the option of stopping the drug, which we call drug holidays. So off treatment, and we can stop it and then proceed later on. We know that in metastatic or advanced cancer, withdrawing treatment, giving it now or later, most of the time doesn't improve or change the outcome. The survival is the same anyway, whether you give the treatment now or postpone it for later. And these are true for patients with stage 4 advanced metastatic disease, and the objective is just palliation. Or we offer optional regimens and schedules. Optional regimens, in short, we have so many protocols, which I should mention earlier. And we give them the least toxic. And we also change schedules. Every week, we can do it every 2 weeks. For every 2 weeks schedule, we can postpone it to every 3 weeks or every 4 weeks. And we discuss with the radiologists shorter or hypofractionated radiation schemes. Usually, most patients will undergo radiation for 3 weeks, 4 weeks, 5 weeks to 6 weeks. In some cases, like rectal cancer, for example, we can have a short duration treatment. They have the so-called 5 by 5, 5 grays in 5 days. So they finish the rectal radiation to the rectum within 5 days. Excuse me. In cancer patients with fever, always rule out coronavirus infection. Now, as in all cases, most tumor types and other disease conditions, we always divide our patients into high priority, medium priority, and low priority. In high priority, patient's condition is life-threatening and unstable, and the magnitude of benefit qualities, the intervention is high priority, which means they have a significant survival gain or improvement in the quality of life. The second is what we call the medium priority patients. Patient's condition is non-critical, but delay beyond 6 weeks could potentially impact the overall outcome, or the benefit qualifies for intermediate priority. And the last are patients with low priority. Patient's condition is stable enough that services can be delayed for the duration of the pandemic, or the intervention is non-priority based on the magnitude of benefit. In short, no matter what we do, there is no survival gain and no change in the quality of life. And for now, we have the problem, as in the previous topic, cancer patients who test positive for SARS-CoV-2 infection. So in general, if our cancer patients develop infection, we hold immunosuppressive therapy. And for patients on steroid, hormonal tablets, on anti-EGFR tablets, we decide on a case-to-case basis. And when can, the other problem is, when can cancer treatment be safely started? We hold immunosuppressive therapy at least 14 days from the first onset of symptoms and resolution of symptoms for at least 72 hours without antipyretics. Once the symptoms resolve, we again retest for SARS-CoV-2 and proceed with treatment only if the result is negative by a second negative test 24 hours or more apart. So this is how we proceed with retreatment in our COVID patients. Serological tests, again, rapid antibody tests, can be used to identify patients with previous exposure and possible immunity. And then if retreatment is going to be done, it should be done in a separate clinic, not in the usual chemotherapy clinic or not in the usual area where we put the non-COVID patient. They have to be treated in another area or another separate clinic if we have to resume the treatment in these patients. So in conclusion, there is no one-size-fits-all approach to delivering cancer care during the COVID-19 pandemic, and no international guidelines. The American Society of Clinical Oncology recommends that clinical decisions be individualized and we should consider the curability, the risk of recurrence with delaying the treatment, the number of completed cycles the patient has already received, and of course, patient tolerance. So all these slides, I just summarized from the different guidelines from European Society of Medical Oncology, American Society of Clinical Oncology, and the Philippine Society of Medical Oncology, and also from up-to-date bulletin as of May 21, entitled Cancer Care During the Pandemic by Uso et al. I think that's the last slide. Thank you very much.
Yeah, thank you very much, Dr. Villalon. Certainly that talk gave us lots of tips, particularly on categorizing those with cancer in terms of the risks, as well as whether there's really a need, no, to give any form of intervention depending on the aggressiveness plus the activity of cancer. Um, for those who are participating in this webinar session, you can type in your questions in the Q&A or in the chat of our webinar. There's actually one question here that I saw in the chat. This is addressed, of course, to Dr. Villalon. Can you comment on the use of thymosin alpha-1 supplement in the management of patients with severe COVID-19 disease?
Well, we have so many drugs, treatment recommendations, so many of them. But we all know that they are not proven as of now. And most of the supplements that are recommended by so many people are not yet in the guideline or have not undergone a real clinical trial yet.
Okay, thank you. For Dr. Agra, although you have answered this here in the Q&A, I'll actually mention this. If 4 to 6 puffs of MDI is equivalent to 1 nebulization, how do we give this to patients having acute exacerbation in the ER? Can we give 4 to 6 puffs 20 seconds apart for 3 cycles, given that we usually give a trial of 3 doses of nebulization?
Yes, the same lang.
Uh-huh. And of course, definitely we would want to avoid any form of nebulization, no? Particularly in the ER setting, especially if there's no negative pressure room there.
So we already have air chambers and spacers
Mhm.
in our institute so that to administer even in patients who have COVID, who are non-asthmatic or do not have COPD, who are coughing and a little bit short of breath, we also use MDIs with spacer.
Okay. For both of you, of course, Dr. Villalon mentioned about telemedicine, and both of you are actually following up chronic patients for COPD and, of course, cancer patients. And we all of us know about the limitations. And so how do you address such problems when of course, some patients will call or text you in terms of how they're gonna follow up, or if they have a new problem? So, of course, telemedicine is a good option. So how do you address problems related to the difficulty related to just telemedicine versus face-to-face consults? Yeah, Dr. Villalon?
Oh yes. Well, we have heard many people talk on telemedicine several times. Usually every other day, every day we hear lectures on telemedicine. And what's happening now is we're at home. If they have most of our patients have our numbers, personal numbers, or they have our patients' cell phone numbers. So what we do is once they text us, if they have our numbers, again, we suggest some form of treatment to these patients, or if they need prescriptions, again, as we all do, we take photos of the prescription and then send it by Viber to our patients. Now we have third parties to entertain these patients. As you know, there are some professional organizations wherein you can enroll and they will take care of the appointments, consultation, etc. But again, in some patients, like the talk of the medical legal doctor yesterday, that if we have some patients who keep on texting you every day, and they get those for every little complaint, if they have your numbers, they text you every day. So in these cases, the lawyer has suggested that we should see these patients in the clinic because that means there's a problem. To avoid some medical legal problems, then we should see this patient personally, face to face in our clinic, so that we can solve all their complaints. So that's what we're doing now, actually. But for patients who, for doctors, some of us will be holding clinics already. Most will be in June, and we usually are allowed to clinic days, 2 days a week to hold our clinics. In this case, we can see them for appointments once we start our clinic. So either we answer them personally by text, or we can apply to a third party who will look after the consultation fees, the scheduling, etc. So either one is can be done.
Thank you. Gwen, any
Uh,
additional inputs? Yeah.
we usually hold video consult because in the absence of a physical exam, at least we can see some indirect signs. The patient's in distress. They cannot complete a sentence. Then we can ask the patient to cough or to do a forced exhalation maneuver to elicit a wheeze. Uh, but we also instruct the patient to, if they have their oximeters or if they have their old records, to meron na kaming canned text message before the appointment, so that they will prepare, especially for patients, they will prepare all their old records, old prescriptions, CT scan or PFT, whatever, and their list of their maintenance meds. Then we instruct them to describe if there's any change in their cough, frequency, character of the mucus, and all those stuff. So, para lang, well, that's a bridge, especially for pulmo and ENT. I think kami yung specialty na may cough talaga, and it's a little bit, we're still a little bit hesitant to start face-to-face clinic for all patients. So we screen them first with telemedicine, and what Dr. Villalon said is right, especially also in the Harvard course. Anybody who would call more than twice, there's something urgent that needs to.
Okay, thank you. But in addition to that, of course, we can incorporate the electronic medical record when you actually do teleconsults at the same time. That's at the same time while seeing these patients. Now, I have a question. We have a question here for Dr. Villalon. No? You mentioned serologic tests can be done on onco. Please expound on the indications. Are these well validated? Meaning the tests for the serologic examinations.
All right. Now, I took that from the ESMO guidelines, the European Society of Medical Oncology guidelines. Now, unlike in surgery, wherein most patients are required before surgery to undergo some testing, PCR test, in most of our cancer patients, we don't require them routinely before chemotherapy or before any radiation treatment. We don't require any form of test unless indicated. This is what all of you have been advocating, that not all patients will need this test. Now, again, in some parts of the world, they are recommending, or they are advocating the use of the serologic test, as I mentioned, as a form of knowing whether these cancer patients have past infection or they have developed infection in the past. although this is very controversial, and you are all the experts on this, and this is the rapid antibody test or the serological test is controversial in the Philippines, and most of you are the experts on this. We don't require them routinely on cancer patients unless it's needed or unless our patients would like to have their test done. So all of you, most of our experts have different opinion on this. Some earlier, I heard a talk on TV just earlier, a few hours ago, that another health expert is saying that there can be some advantage to the serologic test. So it's not really a test which is we should not do, but there are certain conditions that it can be helpful. Now it depends. But what I mentioned to you are how they consider serologic or antibody tests abroad. I'm not sure whether abroad in the UK or in the US they have much controversy on the rapid antibody test, because in the Philippines it's very controversial, as you all know.
Yeah, thank you, Dr. Villalon. As an ID, of course, I do know, of course, the problems in relation to the qualitative antibody tests that we have. These are the rapid antibody tests. No? And number one, of course, all of these are not yet validated, no, in the Philippines. And then second, of course, definitely it can still be helpful for as long as we know how to interpret the results, especially how and when we did the tests for our patients. For both of you, of course, these patients, of course, are recommended to have vaccines, right? And at this time of COVID-19, there are, of course, lots of questions in terms of the interactions related to, again, these antibody tests that I've been hearing and receiving. You know. But of course, both of you will recommend no, vaccines like flu for all patients that you have. Gwen?
Yes, sir. I already mentioned it. Even for patients who are not high risk, meaning younger than 50 and without comorbids, it's still advisable to have the flu vaccine annually.
At walang interaction yun, no? Sa antibody test na nire-require ngayon sa mga return to work.
No,
Wala. No. Sir, about your
Yeah,
cancer
I think,
patients?
well, not all patients you really like to have a flu vaccine or pneumonia vaccine. But unless they would like to, or they would ask us, then it's all right. I think, because to my knowledge, let Gwen correct me, these are not live vaccines. No? These are not live.
Yes.
So it's safe for immunocompromised patients. Is that correct?
Yes,
Yes, these are inactivated vaccines, yes.
yes po.
But of course, yes, Gwen, go ahead.
To be practical about it, hindi siya protective to corona, but at least there's less likelihood that you will present with cough, fever, and it might confuse you and you might get anxious to develop some flu-like symptoms and think you have COVID. So at least you would like to eliminate that.
Any other questions? Wait. I think your presentations are quite clear and definitely been very helpful. Even my prepared questions were answered, no, by your presentations earlier. And any additional advice, particularly for these groups of patients that you handle, aside from what you have said? No? Gwen?
Early consult is advice kasi especially for those with symptoms that are suggestive of COVID infection. You know, a lot of people are so anxious they don't want to go to the hospital. But later, if you consult much later, especially with comorbids, it's going to be harder to manage and you're going to have more catastrophic complications. So please consult early, whether through telemedicine, let your doctor advise you what to do next.
Yeah, before I ask Dr. Villalon, naalala ko bigla, no? yung ating ano kasi kultura, we are very close, no? And certainly ang maraming concerns yung mga kamag-anak, no? So in such cases, no, pag concerns na ng kamag-anak, how do you handle those concerns, no? For you, Dr. Villalon, especially pag may cancer akong kapatid, na may kapatid ako may cancer, very anxious ako on how this patient is gonna be handled, no?
Yeah. most of the time, we talk to the relatives, as you know. We don't really talk to the patient. We talk to the relatives. Most often the children are the ones that are talking with us. So it's the same thing. To avoid any problems, I think we should always explain the pros and cons of the management, whether to for those with newly diagnosed, whether was if there's a case to postpone, those under treatment, if we can delay the chemo or the radiation. So all of this have to be explained. And I think, lastly, I think it's still the decision of the physician, of the oncologist, or any other doctor. It's still his ball game because many of our patients will present in different ways. That's why there's no international guidelines that are advocated because they present in so many ways. So I think as long as we have the basic knowledge of the guidelines, then we can use them properly. But ultimately, again, it will depend on our own judgment.
Gwen, may mga kamag-anak din ba yung pasyente mo na makukulit?
Yes. Pero sila rin, we have to remember, we also have to remind them of the precautions. Because even if we keep our COPD patients at home, sila yung labas na labas, they might be the ones who bring the infection to the patient. So we also have to remind them constantly to exercise precautions. But ano naman, mababait naman sila.
Yeah, there's a question here, no? Actually from Dr. Esther Penserga. No? Again, thank you for both of you. Now, I know on chemo for breast CA has delayed treatment now, no, for the third month. One asks if the recurrence would be more aggressive. Is there fear with basis?
I don't. Is this chemotherapy as an adjuvant? Adjuvant means after surgery you give the chemo to prevent recurrence. So that should be differentiated from the chemotherapy in stage 4 metastatic disease. So what's this patient on adjuvant or on
Adjuvant.
All right. That's why if you are on adjuvant again, it depends on how many cycles you have completed already. If you have not started, then you can start on a later date, a few days, a few weeks. And if this is already, if you are already nearing the treatment, then sometimes we usually give about 6 cycles to 8 cycles. No, sometimes when patient is already on the 7th cycle and the requirement is 8 cycles, when they have the 7th cycle finished and they only have 1 cycle, most of the time we usually tell them that we can omit the 8th or last cycle because they will be putting them at risk if only 1 cycle is needed and they will go to the hospital. Now, the question of Esther, again, we have no data on that. But we know that a recurrence is always worse than compared to if we than compared to the treatment you're giving. Because a recurrence most of the time would be a stage 4 disease if they recur elsewhere in the body. So it's difficult to say because it again depends on the tumor type. In breast cancer, it's quite easy because they respond very well to treatment, and you can give so many forms of treatment chemotherapy, oral, hormone, sometimes immunotherapy. In breast cancer, the management is not that difficult because they respond to so many treatments. If you compare them to the other tumor types, like what melanoma, pancreas, these are bad tumors. So again, it depends on what kind. But a recurrence is always bad, of course.
Thank you. I think there are no more questions here. But just the same, and there are lots of course, comments and and thanks to both of you. Nagpapasalamat sila sa inyo for the extensive and clear discussion, particularly on these two groups of patients who are considered vulnerable. No? I think we can end because there are no more questions, and I of course have no more questions too. Again, salamat sa inyo, Dr. Villalon, saka Dr. Gwendy Agra, and to all the participants, thanks for staying, and we do hope to, of course, just stay safe and enjoy your lunch. Thank you very much.
Yay!
And at least,
Yung mask ni Marga nakakalat, bigyan mo na ng bago yan. Patapos na yun.
hindi